And tell me, so what's the next step? Let's say you get them immune checkpoint inhibitors, this combination immune checkpoint inhibitors. Are there any mechanisms of resistance that you're seeing, or that when they respond initially, but then they stop responding? Where do you think the field is going?
So I think in some ways this may be melanoma 101 repeated. And what I would really hope to see is that not only can we replicate the successes of melanoma with immune checkpoint inhibitors in CSCC, but we also learn from our mistakes in melanoma. I think it's a little too early to tell what the true mechanisms of resistance are in CSCC to checkpoint inhibitors. What is unique about those 30 to 35% of patients that are treated with anti-PD-1 agents such as cemiplimab that don't respond at all right from the get-go? And what is the mechanism of resistance? And that's where I think the interface between the clinic and the bench is so critically important. So I think it becomes important that centers that are conducting research, or centers of excellence for skin cancer and CSCC, potentially develop a biorepository of specimens where we can actually do tumor biopsies before starting treatment, tumor biopsies during treatment, and most importantly, tumor biopsies at progression, if and when they develop progression. Because I think hopefully that will help us understand in a better and more uniform fashion what is the true mechanism of resistance for these patients. Right now, I think it's a little too early to tell.
I mean, it's in melanoma, one of the most, and maybe in lung cancer, we see pseudoprogression, kind of very well described in melanoma literature. What about in CSCC?
I must admit, I have not seen that yet. And I've seen a lot of CSCC. I've treated a lot of patients on this clinical trial and then off clinical trial with anti-PD-1 agents as well. And I have yet to see, I cannot recall anecdotally, any pseudoprogression. In fact, the responses, I would actually venture to say, with CSCC tend to be even more robust in terms of time to response compared to melanoma. We have patients who called us and said, and particularly, as you know, CSCC being fairly disfiguring.
Right.
These are large tumors, and patients call us, 2 or 3 doses into treatment and say, I can notice an immediate difference. My pain is better. My drainage from my tumor is better. Literally within a month. The median time to response was about 2 months in this trial. Some of them have even called and said, the tumor feels different. They tend to be firm necrotic tumors to start with, and then they literally become, for lack of a better term, mushy, like a little softer.
Right.
And some of them have actually sent me photographs where they've said the tumor just fell off.
Wow.
Now that sounds, very, sounds very exciting. It sounds like this is all textbook. That doesn't happen in everyone, but when you see it, it certainly is very nice to see, because we actually have treatment options that are so much better now than we ever did, and certainly far better tolerated. The tolerance, the toxicity profile of cemiplimab is very similar to what one sees with the other anti-PD-1 agents. So again, because we know the mechanism of action, the mechanism of toxicity is almost identical from that. So one does see fatigue, dry mouth, diarrhea, rash, pneumonitis. These are all the most common side effects that we see with this drug. And given that these drugs are now being utilized in virtually every cancer that we have in solid tumor oncology, I think it behooves the medical oncologist, whether at an academic center, community center, to actually familiarize themselves with the toxicities, because early recognition and, most importantly, communication with the patient, early communication with the patient is key. If they start running into trouble, they need to be able to call the office and say, I've now noticed an increase in my stool count. Instead of 1 per day, I'm going 4 and 5 times per day, so that the oncologist knows immediately when to intervene. And I think, we saw that with the learning curve right in the beginning of immune checkpoint inhibitors, where there were certainly far more toxicities reported and more detrimental toxicities. I think with our understanding of these diseases becoming so much better, I'm very, very hopeful, and I think we've already seen that we are in a much better place with treating these toxicities as well.
So what you're saying is, don't do this at home. No, it in the experienced place, because essentially what you're trying to do is that these drugs, though they sound interesting, immunotherapy, the toxicities are not like the traditional cytotoxics, neutropenia, anemia, thrombocytopenia, but these can have detrimental, even life-threatening toxicity. So can you talk about a little bit about life-threatening toxicities that can happen with immune checkpoint inhibitors?
So they tend to be certainly affecting organ systems like the gastrointestinal tract. Colitis is a big problem. With single-agent anti-PD-1 therapy, not so much, but when one starts combining anti-PD-1 and anti-CTLA-4 therapy, for example, as we've done in melanoma, we see a dramatic rise in that, in the incidence of colitis, particularly the grade 3 and grade 4, the more advanced toxicity from a gastrointestinal standpoint. Pneumonitis, so patients presenting with just this sort of faint, they complain of chest pain, cough or shortness of breath. So there again has to be a high index of suspicion to do imaging on these patients. Well, they may just have this subtle ground glass appearance that can rapidly deteriorate into becoming far more symptomatic and oxygen requiring. The other potential life-threatening toxicities, luckily very low in incidence with single-agent anti-PD-1 therapy, includes toxicity to the heart in terms of myocarditis. Seen certainly far more commonly with combination immunotherapy, particularly again anti-PD-1, anti-CTLA-4. Neurologic toxicities, again rare, but certainly can be life-altering and life-threatening. The other ones that primarily relate to hormonal imbalances, particularly hyper or hypothyroidism, hypothyroidism being far more common, adrenal insufficiency, hypophysitis.
That's a medical emergency.
That can be, yes, absolutely.
Right.
And again, high index of suspicion. You have the patient who presents with, you know, doc, I'm just feeling tired and I'm just not able to do everything that I want to do. But otherwise, I'm doing fine. The cancer seems to be regressing. So these are patients that I have a very sort of low threshold for repeating their serum ACTH and serum cortisol levels, because even as recently as this week from single-agent anti-PD-1 therapy in a different disease from melanoma, after 4 doses, I had a patient who has developed cortisol deficiency. So again, sometimes can occur fairly early in that course. So high index of suspicion and good communication between physician and patient is key.